This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Scientific Reports, published in 2026. The paper is titled Predictive Value of Preoperative T1 Slope minus Cervical Lordosis for Clinical Outcomes After Standalone Laminectomy in Elderly Degenerative Cervical Myelopathy.
This is a timely topic, Alara. As our population ages, we're seeing more degenerative cervical myelopathy, or DCM, in the elderly. The surgical management is always a point of debate. Do we go anterior, posterior, do we fuse, or do we just decompress? This study specifically looks at the standalone laminectomy.
Exactly. And for our residents listening, the standalone part is key. No instrumentation, no fusion. In this study, the authors focused on patients over the age of 65. They wanted to see if a specific sagittal parameter, the T1 slope minus cervical lordosis, or T1 SCL, could predict how these patients fare after surgery.
Before we dive into the data, let's refresh the listeners on the T1 SCL. We often talk about the PILL mismatch in the lumbar spine, but in the cervical spine, T1 SCL is essentially its counterpart. It represents the mismatch between the T1 slope, which is a measure of the thoracic inlet, and the actual amount of lordosis the patient has.
Right. In this cohort, the researchers followed patients who underwent standalone laminectomy for multi-level DCM. They used the Modified Japanese Orthopedic Association, or MJOA, score to measure clinical outcomes. The primary question was, does a high preoperative T1 SCL lead to poor neurological recovery or worse neck pain postoperatively?
And what did the study show?
They found that preoperative T1 SCL was a significant independent predictor of the MJOA recovery rate. Specifically, patients with a higher T1 SCL mismatch before surgery tended to have a lower recovery rate at the 2-year follow-up. They actually identified a threshold value using a ROC curve.
What was that cutoff? For the practicing surgeons listening, they'll want a number they can use in the clinic.
The threshold identified was 20 degrees. Patients with a preoperative T1 SCL greater than 20 degrees had significantly worse clinical outcomes. Their MJOA scores didn't improve nearly as much as those with a T1 SCL under 20 degrees.
That's a powerful number. If I have an 80-year-old with multi-level stenosis and their T1 SCL is already 25 or 30 degrees, this study suggests that a simple laminectomy might not be enough to get the clinical result we want. Why do the authors think that is? Is it because the spine is inherently unstable in those patients?
That seems to be the core of it. The paper discusses how a high T1 SCL suggests that the patient is already struggling to maintain a horizontal gaze and sagittal compensation. When you perform a standalone laminectomy, you are removing the posterior tension band, the spinous processes, the interspinous ligaments, without providing any new stabilization. In the high mismatch group, this leads to a further slumping or progressive kyphosis.
Did they look at the postoperative sagittal parameters as well? Did those high mismatch patients actually become more kyphotic?
They did. The study noted that the high T1 SCL group showed a significantly greater loss of cervical lordosis postoperatively compared to the low T1 SCL group. So not only did they start at a disadvantage, but the surgery itself exacerbated the sagittal malalignment because there was no fusion to hold the structure.
This brings up an important point for our residents. We often choose standalone laminectomy in the elderly because it's faster and safer, less blood loss, no risk of pseudoarthrosis, and a shorter anesthesia time. But the paper seems to be warning us that less is more might not apply if the alignment is already failing.
Exactly, Dr. Aris. The authors emphasize that while standalone laminectomy avoids the morbidity of instrumentation, it might be a suboptimal choice for patients who already have a T1 SCL over 20 degrees. In those cases, the neurological decompression is achieved, but the biomechanical failure prevents the patient from reaching their full recovery potential.
Let's look closer at the clinical scores. Did they mention the Neck Disability Index, or NDI? Because we know that sagittal misalignment is often more correlated with pain than with pure neurological deficit.
Yes, they did. The NDI scores were significantly higher, meaning more disability, in the high T1 SCL group postoperatively. These patients reported more chronic neck pain. The paper suggests that the paraspinal muscles in these patients are essentially overworked, trying to compensate for the lack of structural lordosis after the laminectomy.
It's that constant muscular effort to keep the head up. If you have a high T1 slope, you need a high amount of lordosis to remain balanced. If your lordosis is already insufficient, meaning a high T1 SCL, and then a surgeon removes your posterior anchors, you're asking the musculature to do an impossible job.
There was also an interesting mention of the C2-C7 sagittal vertical axis, or SVA. While T1-SCL was the strongest predictor, the SVA also tended to increase in the high mismatch group. However, the study argues that T1-SCL is a more sensitive early marker of mismatch than the SVA.
That's a nuance worth noting. T1-SCL is an angular measure, while SVA is linear. Angular measures often capture the intent of the spine's balance before the linear translation becomes obvious.
One thing I found particularly relevant for our medical students is the patient selection. These were all elderly patients, defined as 65 and older. Why do you think the study focused specifically on this age group?
I suspect it's because the elderly are the ones where we are most tempted to avoid fusion. We worry about their bone quality and their ability to handle a 4-hour surgery versus a 90-minute laminectomy. This paper is really challenging that safety-first mindset by showing that the safer surgery might lead to a poorer functional result if the parameters aren't right.
Exactly, Dr. Aris. The authors emphasize that while standalone laminectomy avoids the morbidity of instrumentation, it might be a suboptimal choice for patients who already have a T1-SCL over 20 degrees. In those cases, the neurological decompression is achieved, but the biomechanical failure prevents the patient from reaching their full recovery potential.
Did they look at the study discuss any limitations? I'd imagine it was a retrospective design.
It was a retrospective analysis of patients treated at a single center. They also noted that they didn't measure global spinal alignment, only the cervical and upper thoracic parameters. We know from other literature that pelvic incidence and lumbar lordosis can influence the cervical spine, but this study focused strictly on the T1-SCL.
That's fair for a focused neurosurgical study. So, Alara, if you're in the clinic tomorrow and you see a 72-year-old with 3-level stenosis, an MJOA of 11, and a T1 slope of 35 with a cervical lordosis of only 10, what are you telling the attending?
Well, based on this paper, that patient has a T1-SCL of 25 degrees. That's well above the 20-degree threshold. I'd be arguing that a standalone laminectomy has a high risk of failure in terms of clinical recovery. I'd suggest considering a posterior cervical decompression infusion, a PCDF, or perhaps a laminoplasty, though even laminoplasty has some risks of kyphosis. But definitely I'd be cautious about a standalone laminectomy.
Correct. And that's the predictive value mentioned in the title. It gives us a data-driven way to steer patients toward the right operation. It's not just surgeon's preference anymore. It's about the patient's specific anatomy.
The paper concludes by stating that preoperative T1-SCL is a simple and reliable radiological tool. It doesn't require complex software, just a standard lateral X-ray or a sagittal MRI where the T1 top plate is visible.
That's the beauty of it. It's actionable. Any resident can calculate this in 30 seconds on the workstation.
Before we wrap up, we should mention the MJOA recovery rate again. The study used the Hirabayashi method for calculating that rate. For the residents, remember that it's not just the final score that matters, but how much of the potential recovery the patient actually achieved. And in this study, the high mismatch group achieved significantly less of that potential.
It's the difference between a patient who can walk unassisted after surgery and one who still needs a cane because their balance and pain are so poorly managed.
This study from the 2026 Scientific Reports certainly gives us a lot to think about regarding our elderly DCM population. It really highlights the shift towards sagittal conscious neurosurgery.
Absolutely. We're moving away from just opening the pipe to thinking about the long-term structural integrity of the spine.
That's all the time we have for today's deep dive. I'm Dr. Alara.
And I'm Dr. Aris. Thank you for joining us on the Neurosurgery Hub podcast. Keep an eye on those T1 slopes, and we'll see you in the next episode. Happy operating!